We now move on to birth impacts with Dr. Mary Willis. She's the assistant professor at Department of Epidemiology, Boston University School of Public Health. I'd like to introduce you to Dr. Willis.
Cool. So I'm Mary Willis. I'm a relatively new assistant professor at the Boston University School of Public Health. And today I was invited to talk to you about the literature on oil and gas development with respect to pregnancy outcomes. And our broad theme here is what do we already know and where can we go next? And at the end, just as a teaser ahead of time, I'll give you a little bit of a sneak peek of what we've been doing at Boston University. So just to put this all into context, the research lens with which we are examining this topic is epidemiology, the observational study of the determinants, occurrence, and distribution of health and disease in a defined population. So we're looking at past data, usually a couple years old, and thinking through to what extent did this particular industry yield an association with a given health outcome. And as we all know in this particular room, 17.6 million Americans reside within about a mile of an active oil and gas development site. And contrary to what some misconceptions out there, there are a lot of people who live near this in rural areas, right? There are lots of rural exposures, but there's also oil and gas sites in the middle of urban areas like Los Angeles, Houston, and relatively near Pittsburgh, where you guys are. And one thing to keep in mind here is that there's a very persistent legacy of this industry. Even if we were to look at what proposed legislation is out there, in California, we actually still are pretty far out from oil and gas actually being not an exposure we need to worry about. Jonathan Buonicore and I recently published this commentary in the American Journal of Public Health where we discuss how the timelines between human health evidence to proposed regulatory outcomes and when this particular industry would be regulated away. And for those of you who are interested in this particular field, the American Journal of Public Health actually published 5 articles on this topic for the first time ever this month, and it's a lovely issue. So you may want to check it out. And as many of us here are very concerned, we also know that even if we were to ban oil and gas tomorrow, say we just stopped extracting onshore, which realistically is probably not happening tomorrow, we still would have lots of abandoned sites to be concerned about. So there's a lot of different meaty components of how the oil and gas industry may affect local populations. And as we know, this industry has multidimensional community health impacts. There are economic impacts wherein some people are getting money from this industry, either by working for the industry or selling off their mineral rights, while others are getting absolutely nothing. There are demographic changes when fracking or other oil and gas development comes to town, right? Suddenly there are new people in your community who may have power who didn't before, or other changes to the social structure in your area. And then there are lots of environmental impacts, which is where I am mostly focused. So the air pollution, water contamination, persistent light and noise, that sort of thing. And a key thing to think about, particularly with respect to pregnancy outcomes, is that depending on which set of exposures one receives, it can affect population health in different ways. Birth outcomes in particular follow very stark socioeconomic gradients. So groups that are already experiencing disparities in birth outcomes, like BIPOC communities, lower income, could have those disparities exacerbated by the double jeopardy of receiving an additional environmental hazard. And to date, there are lots of studies on this topic going back to the early 2010s, where we have some iconic studies out of Colorado and Pennsylvania that really sparked a lot of this movement on, hey, what on earth is happening when oil and gas comes into a community? Why are these infants doing worse? We've looked at things in a variety of settings and across a lot of different time periods. These data generally span from about 1990 through about 2018 at this point. And here's just a smattering of the different studies that are going on and really highlighting that lots of people are working on this topic, right? You will notice there isn't a ton of overlap in authors across these studies. And that is happening in a lot of different settings. And so today there are about 20 good high quality epidemiologic studies that show associations between closer residential proximity to oil and gas development or higher intensity of oil and gas development near the home and adverse maternal infant health outcomes. These outcomes include increased rates of preterm birth, increased rates of small for gestational age, decreased birth weight, increased gestational hypertension, increased congenital anomalies, and increased depression and anxiety during pregnancy. And all of the outcomes that I've listed here, with the exception of gestational hypertension, have been replicated across several different studies in different contexts by different authors. So we're triangulating around this concept that something about oil and gas development adversely influences maternal infant health. And we really need to think about to what extent is this industry creating a hazard for these local mother-infant dyads. However, most of these existing studies are largely based in administrative data. So they're using birth records or electronic health records to conduct these analyses. So birth records being like the regular birth certificate that you fill out when an infant is born, and electronic health records being the information that you see when you log into your MyChart or whatever other electronic health system you may have. So the pros of this sort of administrative approach is that there's population level data availability. You can so you know everyone in the study. You're not necessarily in the study region. You're not necessarily omitting people who wouldn't necessarily volunteer to be in a research study. So you're able to get those persistently marginalized populations passively included in your sample. They're relatively large sample sizes because all recorded live births can be captured. So, right, if you're conducting at least in a cohort study framework, you'll generally have lots of sample size, even in relatively small ranges, allowing you to figure out, hey, is 50 meters a health relevant distance? Is 100 meters a health relevant distance? That sort of thing. And you've got pretty good measurements in these passive samples of birth-related outcomes like preterm birth, because we can measure preterm birth pretty reliably. Most people know within a margin of error whether or not their infant was born preterm, and roughly what gestational age it was when the kid was born. And the other really big positive of this administrative study design is that you've got an efficient study timeline. Once these data are available, and once we've identified the concern, you can conduct these analyses relatively quickly because you don't need to sit there and recruit people, right? It's a little easier to conduct these studies than go out and recruit your own cohort. However, the cons of these administrative data is that first you've got a limited ability to control for confounding. Say maybe something like what was the educational attainment of the birthing parent, maybe the educational attainment of the other parent, but you don't necessarily know things like household income, nutritional intake, daily activities, lifestyle, which can be really critical confounders for associations for oil and gas development and infant health outcomes. Residential location information is also quite minimal in most of these administrative data sources, especially birth records. All you get is where was the birthing parent living at delivery. You don't necessarily get, say, addresses over pregnancy, let alone addresses even before pregnancy, which can be really important because during pregnancy, about 33% of pregnant people move. So the residential location at delivery may not be the most relevant address to use. We also note that the quality of data is lower for maternal health related outcomes, simply because they aren't the point of the birth certificate. So you don't necessarily capture all of the information on, say, gestational hypertension that we would love to see. And the two key ones that I was most concerned about here are that many important outcomes are not included in administrative records. We've heard from communities that people are concerned about incident infertility and increased rates of miscarriage. Neither of those are captured reliably in administrative records, so other data sources are needed to examine those concerns. And also, most of these administrative data sources are kept at the state level, so harmonizing across state lines can be incredibly tricky because while a lot of core information is collected similarly across state lines, the way maternal education is recorded in Texas versus Pennsylvania versus Colorado versus California are all quite different, and you might not get the same quality of data in all states. And so when I first started on my upcoming project, I looked at all the states where we've seen associations between maternal infant health and oil and gas development. I know there's some work in progress in other states, but for now, these are the main ones to consider. As well as two Canadian provinces also have studies on this topic in Alberta and British Columbia. So we see across these states a variety of settings with relatively consistent associations. We might not necessarily find the same adverse health outcome in each study, but we see a lot of different things going on. But at the same time, as many of you here have noted, communities want better data to use to advocate for health protective regulations on this industry. And so I recently received NIH funding to launch a prospective cohort study of oil and gas development and reproductive health. We use the ongoing infrastructure of pregnancy study online, an ongoing internet-based preconception cohort study of couples attempting pregnancy, where right now we have over 17,500 couples across the country, across the US and in Canada. In the current project, we are spending a lot of time on exposure characterization. First, we're doing a lot of work to integrate spatial data together across state lines. So figuring out how can we consistently measure proximity to oil and gas development in Texas, the same way as we measure it in Pennsylvania, the same way as it's measured in British Columbia. This has been the better part of a year and a half working on this particular part of the project. We're also building in some midstream data and other information on things like flaring as we can. We're also conducting a risk perception survey so we can start figuring out who is perceiving the highest risks of living near this industry and to what extent does the stress of perceiving a worse risk associated with these health outcomes. And the part that I'm particularly excited about are these personal monitoring data, where we're using wristbands to get personal air pollution exposures to about 90 different chemicals, and pairing that with household water contamination sample or household water samples from their taps to see if there's any associations between living near these sites and air and water contamination. And then we're linking all of this data onto an epidemiologic assessment of health outcomes that are really tricky to measure in administrative data. So we're going to look at fertility, so time to pregnancy, how long does it take a couple planning a pregnancy to get pregnant? Early pregnancy loss, also known as miscarriage. A few pregnancy complications like gestational hypertension and gestational diabetes. And then we're going to replicate a lot of the existing work on birth outcomes to see if it holds in a prospective cohort framework. Just for context, this is the study design that we are using. This is latched onto the existing Presto cohort data, where we recruit couples before they are pregnant, and we follow them up every 8 weeks for updated menstrual period data and to ask if they are pregnant. We will implement the risk perceptions questionnaire during the follow-up period. And among those who conceive, we follow them from conception through birth, and we also look at postpartum and early life information. We're going to be doing some of this water collection along the way, and we're really excited to see how this works. So I don't have any of the outcomes I just told you about, but I can give you a sneak peek on our first results on preconception mental health. So what we looked at was very simply for now, residential proximity to oil and gas development and adverse mental health outcomes in this particular cohort. We have about 5,000 participants right now who live within 50 kilometers of oil and gas development. 6% are current smokers, so lower than the general population. 38% have attained a graduate degree. We think this is largely due to the fact that these are pregnancy planners, so they have the privilege of being able to plan a pregnancy and are thus slightly higher SES than the general population. 21% of them have an annual household income less than 50K. 58% have been pregnant before, and 87% had a primary care visit in the previous year. You can see here we have pretty good geographic coverage across the US and Canada. In panel A, you can see our harmonized database at this point on where active oil and gas development sites were located. And in panel B, you can see where our participants are located, and that we have pretty high numbers of participants in states like California and Texas, where there's a lot of oil and gas development going on. And so, just as a sneak peek of our results here, we use validated measures to examine perceived stress, depressive symptoms, and psychotropic medication usage. And you can see within 2 kilometers of oil and gas development, this part of the line right here, there is a higher prevalence of high perceived stress among participants who live within 2 kilometers of the industry. For depressive symptoms, we actually see a spike all the way out to about 18 kilometers, but we see very little association with psychotropic medication usage. So there's clearly something going on with mental health. We haven't fully parsed all the details of it yet. And so, next steps, our protocols are in development for a mail-based air and water sampling across the US. Unfortunately, due to various logistical issues, we can't include Canada in the personal monitoring sampling, but they'll be included in the risk perception survey and all the epi analyses. We're launching this risk perception survey among our pregnancy planners in the next few months, and our preliminary analyses with spatial data are in progress for other health outcomes. And so with that, if you're interested in pregnancy study online, you can go to this website here. We're on the internet, Facebook, and Twitter, or X as it's now called. And if you have any questions or comments on this specific research, feel free to reach out now and ask questions or email me at another time. Thank you.
Thank you. Thank you, Dr. Willis. We will now move on to the question and answer session. Go ahead.
Question for you, Dr. Willis. Studies show that something about fracking interferes with normal fetal development, and that's a stunning statement when you think about it. Can you speculate what factors, asthma, stress, et cetera, contribute to this?
So I do not enjoy speculating. I am an epidemiologist, not a clinician, so I would defer to some of the clinicians in the room for more specifics on that particular one. I know it's an unsatisfying answer. I am just not a biologist, and I'm not great at those answers up front.
I think we have one more coming in here. Can you elaborate on your description of recruitment? How are you layering in the recent effects of wildfire exposure?
Sorry, could you repeat that question?
Yeah, the first part was, can you elaborate on your description of recruitment? Maybe we'll start there.
Yeah. Okay, cool. We'll get to the wildfire piece. That's slightly adjacent here. This particular project recruits using the internet. It's an internet-based cohort, preconception cohort study. So we can walk through that. Internet-based, we recruit mostly via online ads, things like Facebook, Twitter, Instagram, all those sorts of just ways where you might be targeted with an ad and you can click on it and join our study. Internet-based recruitment is not necessarily directly representative of the regular population. We've been worried about that, but we know that we've shown in other projects that etiologic associations between internet-based recruitment and standard recruitment in like a clinic actually turn up with relatively similar results. We're a preconception cohort study, meaning that we recruit couples before they are pregnant, so we can calculate incident time to pregnancy. So how long does it take for a couple to get pregnant, getting incident infertility? And then we can figure out, because they're pregnancy planners and testing early and often, we can get reasonably good rates of incident spontaneous abortion or miscarriage as early as 8 weeks, which is about when the majority of miscarriages occur, if I recall correctly. And then of the ones who make it to 20 weeks gestation, we can look at things like pregnancy complications and then birth outcomes among those who make it to a live birth.
Great. The second part of that was, how are you layering in the recent effects of wildfire exposure?
So right now, we are not directly doing that. We just concluded the first studies using Presto data on air pollution and fertility, where we actually found very little effect of between ambient air pollution, so PM 2.5, particulate matter, ozone, and nitrogen dioxide. We found very little effect between ambient air pollution and fertility outcomes and spontaneous abortion outcomes, which was surprising. So we are still trying to figure out why was that result particularly null, both of which are published now. You can look them up. And figuring out then how do we layer in wildfires? What is the next step on that particular part of the process? stay tuned. We have ideas.
Time for one more?
Yep. Yeah, sure.
A question from online. How do you account for your own bias, and how do you attribute studies that look at shale oil development with PEA shale development, which is exclusively natural gas?
Yeah, so our first thing we're planning to do in the study, and we are planning to, when we have sample size, stratify on states, or specifically shale plays, right? State boundaries aren't necessarily aligned with the exact practices going on in an area. So we're looking at them state by state. We will stratify on primarily natural gas being extracted versus primarily oil being extracted. It's just when we're trying to do these national studies, getting the regional specific data is not always as easy as it sounds, because right, we need sample size across all these different regions. So we'll try, and we'll see how it goes.
All right, thank you. Thank you again for being with us, Dr. Willis, today.